Here the volume control or pressure controlled mechanical ventilation modes are acceptable modes immediately following intubation. The peak pressures you have to expect it to be high due to very high resistance because of the severe bronchoconstriction and the resistance along the tracheobronchial tree and the use of high inspiratory gas flows. So you need to get ready to face a peak pressure of maybe 50 or 55, but you make sure that the alveolar pressure, that is the plateau pressure, should be less than 30 centimeters of water despite very high peak inspiratory pressure. Again, FiO2, you can be liberal. You need to give a PaO2 of something around from 60 to 100. Usually, we may require FiO2 of 0.5 and above. You start with 100% oxygen, try to come down, and then see the situation. This is what I was referring to. This phase, the difference between peak inspiratory pressure and plateau pressure is all accounted by the increased airway resistance. This much pressure drop is actually lost in the work of overcoming the resistance through the narrowed or constricted airways. But as long as the plateau pressure is within the normal limit, less than 30, then you are not going to have barotrauma risk. But of course, these patients with emphysematous changes or chance of bullae rupture and all, you need to anticipate pneumothorax incident, but you can keep monitoring for that. But for the time being, keep the plateau pressure in check, and then you need to accept a higher peak pressure until and unless your bronchodilators, your other mechanisms to control the primary trigger like antibiotics, sepsis control, when these work for the patient, then this gap will definitely come down as the exacerbation is controlled. One more thing, after connecting, you can look for a maximum CO2 washout, but permissive hypercapnia, you have to accept it as long as pH is acceptable. You may have to tolerate with a higher PaCO2, because if you go on a very high minute ventilation, this is what can happen or what you might see on your ventilator monitor. Here you can see this is the flow diagram. Okay, this is the exhalation phase. The exhalation, this is not coming back to the baseline. Okay, so that means there is air trapping happening. What is air trapping? That is inadequate exhalation. That will cause some air to be retained from the previous breath when the next breath comes. So this will cause intrinsic hyperdynamic inflation. So this is something to be avoided if you want to treat it. How to treat it? You can simply allow more exhalation time so that this exhalation flow curve returns to normal. Okay, so here the prolonged expiratory phase is the allowance we give so that there will be less of air trapping. This will spring in two terminologies, like something called intrinsic peep or auto peep. Auto peep is something automatically generated or by default generated. Peep is positive end expiratory pressure. So intrinsic peep is something which develops, or positive pressure that develops because of inadequate exhalation. Okay, so this is how it happens. Inadequate exhalation, some amount of air is retained in the alveolar units, so there will be air trapping leading to auto peep.